Thank you, and good morning or good afternoon. Thank you for inviting me to have a talk on the way that HL7 has been used in introducing large-scale COVID-19 testing in the Netherlands. But before I go into the details of that, please let me introduce myself. My name is Robert Stegwee. You can see all my credentials here. What's the important case of... Now, I'm sorry, I'm getting the pre-recorded version anyway, so I have a little problem making sure that we get this. Let me see how I do this. I'll just go through the slides this way, because in presentation mode it won't work, because then it starts to replay what I recorded. Can you see it now?
Yes.
It's still sharing? Yes. Oh, it's paused. There we are. Okay. Sorry about that. You already gave quite an overview of what I've done. I'd like to focus on what I've done recently. In the last 4 years, I've been contracted by the Center for Infectious Disease Control to set up a project about lab information, and specifically around the reporting, national reporting of lab tests for antibiotics resistance. And that's where we gathered a lot of experience in the use of standards for large-scale lab reporting. So in April 2020, I started there, and I will tell you a little bit about how the corona pandemic unfolded in the Netherlands. We had our first case in February. 1 week later, we already had our first death. And that's when regional measures kicked in, just in 1 or 2 provinces. But only a couple of days later, it was clear that something needed to be done at a national level. And even on mid-March, we went into what was called an intelligent lockdown. Not a total lockdown like other places in the world have experienced, but still fairly severe measures. It also meant that we needed a strategy to come out of the lockdown, and that strategy was presented to the Parliament on April 7th. It had 3 pillars, basically: test, track, and report. And it also included work on 2 apps, especially around the tracking and reporting. But as mentioned, I was called upon to help with the testing. What does that mean, testing? Testing, large-scale testing, especially in the public health environment, is a public health responsibility. And in the Netherlands, we have 25 regional centers for public health. And from an IT perspective, you can look at what kind of systems are they using for infectious disease control. 23 have the same brand of system, but 2 had a different system. But that doesn't mean that it all worked in the same way. And on the other hand, the Center for Public Health, except for 1, don't have their own labs. So they have to contract with outside labs to actually carry out the COVID-19 testing. And we had, at that time, 62 accredited labs for COVID-19 testing, including 8 what we call pandemic labs. Those are labs that are not regularly doing the patient diagnostic services, but are, for instance, veterinary labs or blood transfusion labs that also have capacity to support COVID-19 testing. So that's what we were facing with. I'll share with you a few observations on what has been going on. I already hinted at it. Each regional center for public health has their own way of working, which may be very sophisticated, but also often it's paper-based, and it actually meant manually rekeying test results. Even though they were delivered in an electronic format, there was no interface to their system to actually accept those test results into their system. And for infectious diseases, that's not really a problem usually, because well, it works fairly well if you have 500 tests per day, which was the average before the outbreak. And 2,000 tests was a bit of a stretch, but it still could be done in early April. But we were aiming, or the National Center for Disease Control actually looked at 30,000 to 70,000 tests per day. That was their scenario. And that surely cannot be done by all kinds of manual entries, etc. So the choice was made as part of the strategy to make testing available to the larger population, everyone with mild symptoms, and that's what triggered the development of a new system. So that's the strategy that we worked on. And we pitched that strategy on April 6th, just a day before the overall strategy was pitched to or presented to the national government, or the national parliament, I should say. And it actually meant we need a new system. We cannot work with those 25 individual systems within the public health center. We need one system for all public health centers, so that we have one hub from which to actually organize the testing. It does the registration of the people that want to be tested. It does the triage. Do they have mild symptoms? What symptoms do they have? Scheduling to one of the test facilities that are operated by the public health centers, where the swab will take place, and finally the system will, after of course sending the specimen to the lab and getting the results back, it will support in reporting those results back to the patient or the person that actually went through the test. And only when it's positive, then the patient is handed over to the existing system for source and contact tracing, so that we actually know where the people got the infection. In the beginning, we had 8 pandemic labs, as mentioned, 27 contracted labs, and we also envisioned a phase 2 after the June 1st go live moment, when people were actually being tested on a large scale. We foresaw a phase 2 with another 19 labs to help get to that number of 30,000 to 70,000 tests per day. So that's the strategy that we pitched, and on April 8th, we actually got the go-ahead and the funding to start doing this. So what's the challenge that we have? It's basically an interoperability challenge. At least my perspective was the interoperability challenge between the new system for registering and administering the tests and the labs that had to carry out the test. You have to have one HL7 message to order a test, and one HL7 message to report the test result. You need to agree upon the code to use, in our case, a line code to identify the test. The SNOMED CT codes to identify the sample, the line codes to identify the test result, etc., etc. So there's a lot going on, and also just simple things as a barcode. We had to invent a barcode for the samples. And we came up with this one, identifying the lab, one of the 35 labs that were in operation in the first phase, with first 3 digits, and the rest is just the code for the sample. But you need to agree upon all these things. So that's what we really needed to do in a very short term, and also roll out the secure network for ordering the tests and getting the results back, connected to all the different labs, and we had to do that within basically a month and a half. That's quite a challenge, I can tell you. But if we go to the next page, we actually, in the first week, starting June 1st, we carried out 50,000 tests. So that was not bad. It was well over the 2,000 tests that we're doing on a daily basis. So the system worked, and we did get feedback from the labs that this would not have been possible with the current system, with the old system. and the old way of working. So that was quite successful. And of course, the question is then, how did we achieve this, this success? Basically, it's because we already had invested in the HL7 standards, and that's where I mentioned my previous work with antibiotic resistance. We actually had agreed upon as a community that these are the HL7 standards that we need. This is the national lab code set that we want, which is a coordinated subset of LOINC and SNOMED. Because if you look up SARS, or you look up any specific test within LOINC, you will find a number of possibilities, and you need to have a group, a dedicated team that really coordinates how to use LOINC and SNOMED within your country to achieve a true interoperability. And this team is consisting of medical microbiologists and also some of the application management professionals that are responsible for the laboratory information management system. So we had already worked on the antibiotics resistance with most of the labs and the vendors of their laboratory information management system. So there was a community out there that we could call upon. In all, about 100, 150 people across the country were actually working on this, and we had easy contact with them. But of course, most importantly, the urgency was there. We have been working for 4 years on the antibiotics resistance, and we did get 20 labs to sign up, but only 5 labs to go live. And now within 1 month and a half, we had to get 35 labs live. So, and we succeeded because everybody understood that this needed to be done in order to facilitate the large scale testing across the country. And that really made the difference. Of course, urgency also means that there's no discussion on finances, and people will pitch in terms of finances from the ministry whenever there is a hurdle. So this is really what we did, and how a common investment and community building around the standards really helped us to achieve this. Of course, the question is, where are we now? We actually introduced a phase 3. We did get the other 19 labs on phase 2 live in the course of August. But also in the course of August, we already saw a rise in the number of tests and the number of positive tests. So we had to engage more labs, and we had to go outside the Netherlands to actually contract labs and connect them in the same way. And basically last week, we had over 300,000 tests. So we went from 50,000 in the first week to over 300,000 last week. And we have almost 3 million tests running. Just for comparison, we're a relatively small country. We have 17 million people. So we're basically the size of Greater New York City. And that's all of our country. But still, we managed to organize our healthcare system in such a way that we need 62 independent different labs to actually do this, and extra labs outside the Netherlands to help this. Given the pressure on the large-scale testing, priority groups have been identified, and we are also looking into new tests being implemented, including a breath test, which has a very good result on the negative side. So if the breath test says you're negative, then it's sure that you are negative, so we can eliminate a whole group of people going through the PCR testing. That's the gold standard for SARS-CoV-2 testing. And it helps to have the HL7 infrastructure in there, because you can just easily point at what needs to be changed in the interface to have this new test implemented. Also supported again by the active community and by this dedicated group of professionals that is managing the terminology that we're using. So that's my talk for today. If you have any questions on what we've done, or just drop me an email later, but I'm happy to answer any questions right now.